I spent at Tairāwhiti doing my rural hospital training, I was fortunate to have the exposure in the area gave me the opportunity to have a broad coverage of rural health across the board. As part of this opportunity, I had the chance to be peripherally involved in the echo screening for rheumatic heart disease. Our next speaker is one of the principals of that research in New Zealand and the South Pacific. May I present, supported by the Heart Foundation, paediatric cardiologist Nigel Watson.
Kia ora, and thank you for inviting me to this a very good conference. I wanted to be a country GP, well, I used to call it a country GP, a rural GP, because I spent a lot of time in Fiordland and Aspiring National Park in the hills, and I thought that would be the way to go. And I did some my house surgeon years in Auckland and Hawke's Bay, and I saw a lot of rheumatic fever, and I went across to Britain and did some paediatrics, and then I decided, in fact, that I was much more interested in paediatrics than adult medicine. So I trained in paediatrics, and then I went to Canada into paediatric cardiology, getting further and further away from rural GP scene. And then I realised, of course, that the only place I could work in New Zealand as a paediatric cardiologist was Auckland. But it was, I came back 8 years later, and my first child in the clinic was a child with very bad rheumatic heart disease. So I've been around the world and never seen rheumatic fever again. So it's what I do with my work. I see children mainly with congenital heart disease, and I close holes with catheters, and it's very satisfying on an individual basis. But my passion over the last 20 years, especially in the last 10 years, has been rheumatic fever research. And so I want to share some of those time with you today. John Noitze was really the father of paediatric cardiology in New Zealand, and he, there was a number of, after the Rheumatic Fever Working Party in Rotorua in 1983, there were a number of publications, and John's article was entitled Rheumatic Fever, an Unsolved Problem in New Zealand. And unfortunately, I think it remains so, but there has been a lot of work and endeavour. And I regard rheumatic fever knowledge really as being, there's three pillars of knowledge. We've got a lot more data now. There's a lot more data in New Zealand and in Australia and around the world. But these are still the three big facts, if you like. And that's the first one there. Without group A streptococcus, there would be no rheumatic fever. And so this was an article written by Jonathan Karapeterson from Australia. And he has really put rheumatic fever on the map internationally and challenged a lot of governments and got a lot of NGOs involved. And it came from his PhD in Australia. But I worked with him on this article, and you can see there all the various different factors about why we think the first episode of acute rheumatic fever occurs. But we still don't really know. We know overcrowding is important, but we see children coming in with just one child in a family getting rheumatic fever. So there's a lot we don't know. There's a lot we don't know about the host. But we do know that if you don't have streptococcal infection, you won't get acute rheumatic fever. And I want just to talk a little bit about acute rheumatic fever, and the clinical diagnosis still depends on history and examination and investigations, but there remains no laboratory test for acute rheumatic fever, and I think that's going to be the same for many years to come. So it's a diagnosis of an assessment of probability. And I won't go over your medical school days about the Jones criteria, but basically it was fairly clear that the Jones criteria have become ever more specific because they are at the American Heart Association. They're for America. That's their American Heart Association. It's for their country. But of course they're hugely influential. They have a lot more time to write these very clever articles, if you like. But they were concerned about falling rates of rheumatic fever where it's no longer endemic. They were concerned about overdiagnosis and even about insurability. Whereas the rest of the world, in fact 80% of the world still, there are populations with endemic rheumatic fever. So we're much more concerned, and of course in New Zealand it's a Maori and Pacific problem. We're much more concerned about underdiagnosis and public good and reducing the burden of rheumatic heart disease. So just to go to some clinical data, in Australia, Jonathan had found that 90% of acute rheumatic fever have joint symptoms. And we know it's very easy when it's classical migratory polyarthritis from the knees going to the ankles or the elbows and the wrists. And that's going to be rheumatic fever. But in fact, they had 17% had monoarthritis. And in the 1990s, the clinicians hadn't put those people on secondary prophylaxis, and a lot had come back of the ones with monoarthritis. There was work from India, and the work from New Zealand, this was part of Diane Lennon's primary prevention study that Johan Moreau, we've heard about this afternoon, and Leslie Voss and myself, we were part of the case ascertainment committee. So we went through all the files very carefully in that time period. Some schools were getting throat swabs and some schools not, to ascertain whether there was a true diagnosis of acute rheumatic fever or not. And you see there at the bottom there, 93% joint symptoms in acute rheumatic fever, so just the same. So as you present with acute rheumatic fever with a polyarthralgia or polyarthritis, but again, we found that 16% had monoarthritis. And of course we know that you're not supposed to give non-steroidals, aspirin or Brufen, until you see if it evolves. But in New Zealand, we were finding that of those, I think 9 of the 11 had actually had received aspirin in the casualty, or before they had evolved. So we take that in New Zealand now as a major criterion. And of course, you'll know that the guidelines, Denny Lennon and I chaired these. Came out in 2006, the first edition, but we stress when even though 50% have classical migratory polyarthritis, the other half with their arthritis, it's atypical or it's a monoarthritis, you need to look for other causes. And we need to re-educate out the orthopedic department every few years that when someone comes in, it looks like they've got a septic arthritis, obviously they have an aspiration. If it's negative, they must think that could this in fact be rheumatic fever. And so there's the list of arthritides that we have seen over the years that someone thinks it's acute rheumatic fever, but in fact it's another post-reactive arthritis. I won't talk too much about subclinical carditis, but basically about half the children that come in with acute rheumatic fever have clinical carditis, and it's very audible, and the X-ray and the echo support the diagnosis, and it's very easy to see that as carditis. But we were seeing in the 90s, when echo Doppler came in, a number of children with classical acute rheumatic fever that had inaudible rheumatic carditis, so mild mitral regurgitation or mild aortic regurgitation. And John Noitzi and I, under very carefully listening conditions, we just couldn't hear these. So we started writing about these and challenging the American Heart Association, but they said, no, you have to, it was extraordinary, they said, no, you have to be able to hear it. And so basically what we've done in the last decade is New Zealand, Australia and other countries have just gone around the AHA and said, okay, well, we're going to use it anyway because it's just ridiculous not to use echo to its fullest extent. So going on to the second pillar of rheumatic fever knowledge, and that is just to remind you about the recurrences of acute rheumatic fever can be unequivocally prevented by continuous administration of benzathine penicillin. And it's worth remembering that it was really, everyone who comes into the field of rheumatic fever thinks, oh, why do they have to have those nasty injections? Why can't we just have oral penicillin? And so there was really a study, unintentionally if you like, in the Gisborne area. They had extremely high rates of recurrences in the 1970s. Intramuscular penicillin was implemented, and David Frankish came up with this graph, and cardiac surgeons and cardiologists like these sort of graphs, but they talk about the freedom from recurrence. But if we turn it the other way around, we can say that within 6 years, 35% of those children who are taking oral penicillin, probably not taking it, in fact, had recurrence, whereas only one child of the 51 had a recurrence that was on intramuscular penicillin. And that's been the same all around the world. And this Cochrane database showed all the American and the US data, and there was a clear difference here that the intramuscular is better than oral penicillin. So the rest of the talk, I'm going to talk really more about severe rheumatic heart disease and how it shortens your life. I'll just have a... And of course, that's what I deal with in my clinical practice. We see children with severe rheumatic heart disease. We've got to decide whether they need to have an operation or not. Let's look at some of the data that supports the statement that severe rheumatic heart disease shortens your life. So in the days of Jones himself and in 1940s and 50s, very high mortality, obviously before penicillin, if you had rheumatic heart disease. And even today, in places like Nigeria, Ethiopia, and India, your mean age of death from rheumatic heart disease is less than 25 years. But a lot of these people will not be getting penicillin. They'll be having recurrence after recurrence of rheumatic fever, of acute rheumatic fever, and their rheumatic heart disease worsens and worsens. In New Zealand, we're slightly better in that the mean age of death is higher at 55 on a recent paper by Milne. But of course, it's the ethnic disparities which are so appalling, so that Maori and Pacific are 10 times likely to more die than New Zealand European if they get rheumatic heart disease, and even worse in Australia. So some of the statistics for New Zealand, that chronic rheumatic heart disease, of course acute rheumatic fever is notifiable, but chronic rheumatic heart disease is not. But you can see there that the actual number of deaths per year running along at about 150 and maybe even rising up to 2006. But the morbidity is very high, so 600 to 800 admissions per year, and they're obviously mainly in young adults, some in children, but much majority in their 20s and 30s and 40s, when of course they are often the social disruption for that family is enormous. And just to introduce that 40% of rheumatic heart disease adults do not have a history of acute rheumatic fever. So they either can't remember it or there's actually clearly no evidence of it happening, and we'll come back to that. I just want to talk about a couple of databases we have access to in Auckland. One about tertiary rheumatic heart disease, like management, and one was the Green Lane National Women's Database with 225 women. You can see it's historical, but it's some very important data, and it's quoted all around the world. And it's looking at types of cardiac surgery. What sort of valve should you have? And so, the National Women's people came across the Green Lane and said, look, we're very concerned about if you like, the carnage and morbidity of women with prosthetic valves, with the whole management of heart disease in pregnancy, especially rheumatic disease. So you see there that if you've got a bioprosthetic valve in the mitral position, so that's a tissue valve, your survival is better than if you have a mechanical valve. And same look at thromboembolic events such as stroke and hemorrhage and the valves clotting up. Mechanical valves way worse than bioprosthetic valves. But the valve survival is not so good. So you're having to reoperate if you put a tissue valve in. And that's the same all around the world for adult data. So there's this problem that it's better, less morbidity with a tissue valve, but you have to reoperate. In the aortic valve position, we know that Sir Brian Barrett-Boyce really mastered the homograft, and Alan Kerr was another great exponent of that. And there were 41 pregnancies and 21 women, and they did very well. 2 women developed heart failure in pregnancy without valve-related complications. And that was the data with prosthetic aortic valve was very bad, very poor. And so clearly the implication for surgeons, for women in the childbearing age with either having a mitral prosthesis or aortic prosthesis, you should do a mitral valve repair, or second best would be a bioprosthetic valve. Even though both of these you may need to reoperate later. But unfortunately, in the current era, not all research is translated into good clinical practice. And so when I looked up the data for that 5-year period, 2004-2007, for women, the repair rate is only 16%, and the bioprosthetic rate was not too bad, 29%, but still 55% being replaced. Some valves are so damaged that it doesn't matter who the surgeon is, you can't replace them. But, you know, I put myself on the line when I confront the adult surgeons with it, with this data. And so they say, well, you know, are you doing any better in your pediatric area? And in fact, so we looked at our area, and here we have the Green Lane Starship series, 1990 to 2006, retrospective review again, but there's a lot of data here. Rachel Webb was my fellow 2007-2008, and this study went on so long I went to my next fellow, Bo Rumenyi. Kirsten Finucane's our senior paediatric surgeon. Tom Gentle's one of the other paediatric cardiologists. So another 212 patients, and follow-up took a long time. It took we hoped to finish it by 2008. It took to 2010 but we really searched very hard because, again, the population who have got rheumatic disease, they're often moving around, and half, of course, we do serve the Pacific as well. Half of the patients actually came from the Pacific Islands, mainly from Samoa and Tonga. And we looked very hard. Some of you may have had phone calls about trying to track down some of the follow-up. And we had 91% complete follow-up and another 7% partial. So it took a lot of time to get this data, which is, you know, when you read a paper that says I had 100% follow-up in rheumatic work, you really start to question the surgeon who wrote it. But anyway, our first paper about isolated mitral valve surgery is just being accepted. And this shows here that the mitral valve repairs have done non-statistically, but they were clearly heading towards being better than the mitral valve replacements in terms of survival. But freedom from all valve-related events, meaning did they get thromboembolism, did they have endocarditis, we now see that the repair is done much better than the mitral valve replacements. And so we've really had, this is not just from this data, but Kirsten has been leading our team to do a valve repair whenever possible. And so we spent a lot of time planning with the transesophageal echo prior to the theatre, during the theatre, and then at the end of the case, is that valve acceptable, even though you know that you might need replacing. And what was very exciting about this data of this cohort was that the revision rate was no higher in the repair than the valve replacement rate. So that's different from the adult data where the revision rate is higher in the repairs. So that really, we continue, and Kirsten and now another surgeon, John Archer, we're getting about 90% in childhood can get a mitral valve repair. Now I want to move on now to rheumatic heart disease and screening. And I just want a bit more data about what's the natural history of rheumatic heart disease with good secondary prophylaxis. And interestingly, I mean, this statement here, no mild or moderate carditis at the end of your acute rheumatic fever, you just won't go on to get bad heart disease 10 years later. So you really revert to a very normal life expectancy. There's a paper from Millikan, a nursing thesis, and there's another big study from Ross Nicholson and Denny Lennon in South Auckland looking at that now. But we know if you've got severe disease, you have a poor prognosis because that valve, if you like, takes, and the muscle is maybe impaired, and that's been well proven over many years that your prognosis is poor once you've got to severe disease. But, as I said earlier, 40% of adults presenting with rheumatic heart disease have never had an episode of acute rheumatic fever, and there's two good papers to support that. We haven't got the data in New Zealand. Why can it be silent? And it's silent because you have to have severe valve regurgitation before you become symptomatic. But if you think about it, some of the clinical episodes that in fact have clearly had an episode of rheumatic fever in the past, we sometimes see a child or an adult comes in with a heart murmur, they're referred, you've heard them, you've referred them up, and they turn to, oh, they've got rheumatic heart disease. That's not that common. Indolent carditis, so a child who's actually lost weight and be tired, their inflammatory markers may no longer be up, but they've clearly got established chronic disease when we look at them clinically on with echo. Even with our children we get with acute rheumatic fever in New Zealand now, and obviously we have a very good, if you have sore joints you present and by and large you'll get diagnosed, a lot of the times we see chronic changes, and we can't tell how long that's been going on for. So a lot of what we call acute rheumatic fever are in fact acute on chronic. Just to go back, in the last 3 years we've had 2 children who have come in with indolent carditis, and they've got such bad muscle function that they've actually, valve replacement is not going to be helpful, and they actually end up looking at cardiac transplantation. Sydenham's career, there's a lot of literature on that basically over half of those have subclinical carditis and rheumatic disease. Bacterial endocarditis, another paper by Rachel Webb, found that from all comers from bacterial endocarditis in adults and children in the 10-year period, 18% of those, the underlying core valve problem was rheumatic. Pregnancy and mitral stenosis, that's been known for years. That might be the first presentation of rheumatic heart disease. And some, not very many, obviously there's multiple causes of stroke, but some of those in fact are found to have atrial fibrillation because of rheumatic heart disease. So if you add all those clinical entities up, in fact that's why it adds up to probably 40% of people have rheumatic heart disease without evidence of acute rheumatic fever. And so there, if you simplify the pathogenesis, on the top we've got the ones that present with sore joints, but on the bottom is this asymptomatic group, and of course that's just going to smoulder along without penicillin interrupting their pathogenesis, and you'll end up with rheumatic heart disease. And in 2007, the French group, they combined their data of Cambodia and Mozambique, and basically this was the number of ones they could hear. And then when they did the echo, they could see all these, 5 to 10 times more higher with echo. And there's the portable echocardiogram. There's a sonocyte out in the, in the exhibition. And so these are portable, and they've now, of course, some of you have even used the handheld ones now, even more portable. And so our first study was, Rachel Webb did a lot of the work, and I was helped to just design it really and run it. And so we asked that question: what's the prevalence of undiagnosed rheumatic heart disease in high-risk children in New Zealand? And we came up with the logo, the Healthy Heart Study. We had multiple funding, including the Heart Foundation, who supported me today. And we asked, the simple question is, what's the prevalence of rheumatic heart disease in New Zealand? What's the sensitivity and specificity of auscultation, and is it feasible? But as you know, there are many challenges of auscultation. Maybe in India, when you can do a screening program where you have, by and large, children with thin body habitus. In New Zealand, Maori, but especially Pacific, are much bigger, and it's really quite hard to hear murmurs. There are also a lot of false positives and false negatives. And we went to Counties Manukau, and that was the planning, ethics and screening, and we got funding. And we went to 7 decile 1 and 2 schools. And so it was a 3-stage registration, auscultation, that's Rachel here doing the auscultation, and echocardiography. And we looked at valve structure and at valve regurgitation, and assessing them whether or not you had rheumatic involvement. Ethnicity, obviously in South Auckland, dominantly Pacific, and the second biggest group was Maori. And the results, we found 6 cases of 1,142 children had definite rheumatic heart disease, 2 with severe mitral regurgitation, 4 with mild disease. And that was in that same, it wasn't the whole of South Auckland, it was just the 7 schools, but in those same region, there were already 6 cases on the Auckland Penicillin Secondary Prophylaxis Register. So, if you like, for every one that we detected, there was already one already known. And there were 16 cases with probable RHD. When we looked at the results for echo versus auscultation, in fact, Rachel was quite good over here. When she heard mitral regurgitation, she was usually right, but she didn't pick up many subclinical ones. And so the sensitivity, in terms of auscultation as a screening, it was poor in terms of sensitivity. We suspected that, but we had to prove that. So clearly, we were able to show that screening was feasible, and that it was the first study really in a middle-income country around the world that with very good secondary prophylaxis, that screening could have a role. And where did it actually come in the different? There's the Cambodia and Mozambique figures. There's Tonga. There's Nicaragua, and there's counties Manukau. So in fact, it was at the sort of lower range, those with definite or probable disease. So really quite worrying. And so we published that, but we also pointed out in that first publication that not all valve is rheumatic. You might be looking for rheumatic, but there are some congenital variations of the mitral valve, and they were very important to exclude. And then, as we've heard, we went to Ty Rafferty, and Jeff Cramp was the public health physician that led that program. And so now we've been to those regions there, and the Auckland regions, the South Auckland study and the North Shore study, that was a control group, if you like, of education decile 10 that was by research funding. But in the other areas, it was really a very good partnership by the paediatrician, public health, nursing and cardiology, and with very good community buy-in. So as you know, and I also want to acknowledge Tariana Turia's putting rheumatic fever really on the map. We've had a lot of academics, especially Diana Lennon, canvassing for acknowledgement about rheumatic fever over the last decade or more, but it's really been Tariana Turia who went to the National Party and said, this is going to be a priority, and she bartered with them, and now there's a lot of money going into primary prevention. And in this echo screening, you can get a lot of good advocacy for your primary health educating in schools at the time when you're educating them about or explaining about the school echo program. And so these are the results here, but the definite disease we see between 0.5 and even in the Bay of Plenty here, the rates were lower, but it was still that 1-to-1 ratio of numbers of children on the register. The same number were found again with established rheumatic heart disease. And then there's the borderline group here. Like in any test, there's always going to be ones with a borderline result, if you like. And in the North Shore, we had 400 children, decile 1 and 2. As expected, no definite rheumatic heart disease, but there were 2 children who had a borderline result. So they had mild mitral regurgitation, which we didn't attribute to a congenital lesion. So you can take that 2 ways. You can say, well, okay, you've got more borderline children in the high-risk group, so that's more likely rheumatic, but on the other hand, we don't want to put them on penicillin because, in fact, you can see in the low decile group, which we didn't suspect that they're rheumatic. So we took this, even before we did the low prevalence region, we thought we were best to not recommend penicillin for those with possible or borderline findings. Is this a suitable test as a screening program? And the New Zealand guideline groups have pointed out that it's, they've got different definitions being used. We don't know the natural history of this disease as found by echo as opposed to found by clinical, and there's no high quality RCTs. And we agree with that. And one of the next steps we took was really to look at the standardising criteria, because people were using different criteria around the world. And so, again, with Jonathan and I, we found Bo Ramenyi, who's a paediatric cardiology trainee in Australia, and she came and worked in Auckland for 2 years with me. We had multiple funding, and we got an evidence-based guidelines for diagnosis of RHD. It was a really great study to do. We had 21 investigators from different continents. We could look at the web. We had a web-based design, so we could look at the echoes online. You report them, and we looked at all the literature on echo and pathology and surgery, and what really is rheumatic and what's not. And we'd only had one meeting when we all got together, and we came up with our guidelines, which the World Heart Federation have adopted as the gold standard, if you like. And so that's looking at the sort of minimal evidence, the minimal degree of changes that you can say as definitely rheumatic. Severe disease, any cardiologist, cardiac surgeon know that that's no problem. It's the lower end. What is definite disease? So that's going to be very helpful for identifying comparing studies between countries, helping reduce false positives, and really raised the threshold, because clearly a lot of places were including the upper limit of physiological valve regurgitation in their numbers, if you like. And it's going to help, it'll be very helpful if and when vaccine trials start. So what can we say about echo screening internationally in the past 5 years? It's clearly shown that confirmed the pathogenesis, if you like, that there's a lot of subclinical disease. It's definitely helped increased advocacy for better control, especially in the Pacific. And in fact, Toa, the leading paediatrician in Tonga, she's continued from an original study in 2006 and gone on and had Australian echo techs come over, and they've actually screened now 90% of school-aged children coming through at about intermediate school years. And it's not proven because you couldn't counter RHD beforehand, but we are just not getting the referrals now from Tonga. One of our, Tom Gentles, goes to Tonga, and he is just not seeing that severe disease in the children that he's seeing. Clearly there's a long tail of adult disease like there is in New Zealand. But that's the scientific community say, well, that's not good enough, you actually have to prove it. So how do we show that the natural history of echocardiographically detected RHD really does go on to progress? And so what we're going to do now is to try to prove the natural history, if you like, is to look at a registry data. We looked in our international standardisation group at an RCT, but other than New Zealand and some parts of India, some parts of South Africa, most secondary prophylaxis is not nearly as good as ours. So by intention to treat, if you were to enrol people, some of the investigators said, well, you know, we couldn't persuade our public health physicians if you weren't going to offer, you couldn't randomise people because we believe penicillin going to work. Others would say, well, we'd have so many dropouts because they would fall off. So what we've come up with is actually do registry data. And so we predict that if we enrol people internationally, not one country is really, we're not going to have the numbers to do it on your own. We would expect to see, anyone can intend to treat with penicillin, and we think we will see a difference between good prophylaxis and poor prophylaxis. So that's our next international endeavour. But really the conclusions in New Zealand about echo screening is that, and about rheumatic heart disease, is that we know that it certainly shortens your life. Morbidity is very high. There's a lot of admissions per year. Echo screening is clearly feasible, and we have found consistently in the rural Maori areas around New Zealand and in the urban areas, especially of, I didn't point out, Rotorua was the latest area, that we're finding 1 to 2% incidence of rheumatic heart disease where they haven't got a history of acute rheumatic fever. So we are recommending to the ministry that they should continue to screen in targeted sites. Thank you for the opportunity to speak, but I think as we, in 2013, unfortunately, rheumatic fever is still an unsolved problem in New Zealand. So thank you very much.
Thank you very much, Nigel. I mean, certainly your data is very grounding for all of us in rural practice, and your work is a fine example of good networking and getting connected. We've got time for a couple of questions from the floor. If anyone has any questions down the back, thanks.
Hi, I'm Brian Moore from Temuka. Just a question. In your earlier data with regards to prosthetic valves and the biomechanical valves and tissue valves, with the biomechanical valves, obviously that data is really early. It goes back, you know, it's early 90s where it's ended. What percentage of those patients with those valves had star valves as opposed to the more modern valves that are used nowadays?
Yeah, you're right. The star valves, there would have been some of them. I wasn't involved in that Green Lane National Women's data, but there were no starred valves. They'd really stopped by 1990 in the children's data. So yes, the new Onyx valve is hopeful that you could maybe run on low warfarin without the need to check levels, but that's not proven yet.
Peter Rodwell Oamaru. We know it's a specific bacteria. Where is the vaccine?
Well, the vaccine is a long story, but basically it started in the 1920s, and then it all went fucked in the 1950s when, in the American clinical trials, 3 out of 20 got rheumatic fever, and that really set back. Then you go to the problem. The microbiologists say that the actual the group A strep is it's got this very resistant outer layer. It's very hard to create a vaccine. There's work in the States from Jim Dale's group. There's work in Queensland, and now again, I think probably through Rotorua, John Key and the Australian Prime Minister have said, why don't we have one in New Zealand? And there's going to be a working group next week, and Jonathan Carapitas is coming over, and Denny Lennon and all the basic scientists, and they're going to try and look at can they use the US. There's 3 candidates that we could use in New Zealand and Australia. So yeah, but Jonathan Carapitas says 5 years ago. I've always said it's 10 years away, and I think it'll be at least 10 years away.
Thank you. I'm David Wilson with GP in Whitianga. I've just got a very practical question. I think a few years ago, Diana Lennon said we should be treating, very racist, but all Maori and Pacific Island treat children with sore throat with penicillin. Should we still be doing this?
Well, in fact, that's what it's in the New Zealand guidelines. Part 2 and 3 is all about primary prevention, and so therefore, yes, if you are Maori or Pacific, aged 3 to 45, and you present with a sore throat, then you should have a throat swab, and if it comes back as a Group A strep, then you should have 10 days of oral penicillin or intramuscular 1 shot of IM benzathine. And so that is what the primary prevention rollout is all about, is in high-risk regions, that program of swabbing children and those with a sore throat and swabbing, not treating strep carriage, but treating those with a streptococcal pharyngitis with penicillin.
Should we wait for a positive result?
If you don't think you're going to see that child again, no, you shouldn't. There's a lot of debate about, and there's a lot of stuff written about, can you separate an upper respiratory tract infection, a viral illness, from a streptococcal, a bacterial pharyngitis. And as you know, you see these children, I don't see those children. Sometimes it's pretty clear when you've got a big cervical nose and a tongue hanging out, then that's streptococcal, more likely bacterial, and other times you've got runny eyes and a rash, and it's much less likely to be. So, if you've got time, the recommendations is to do the throat swab and go on that. My own sort of take on this is that in the regions in the world, and in the French Caribbean, in the United States, in the Army barracks in Baltimore, and there's one other place where primary prevention has been helpful at getting ARF rates down, they used long-term benzathine, but here we're using oral. So, that's what we're going with at the moment, but, in a few years, 2 or 3 years' time, if the ARF rates are not falling, then I'm wondering whether, that the scientists may push for benzathine. Because again, it's very, even the 10 days of oral penicillin, is it taken for that period? And, I think the family should be given a choice. Do you want one shot now, or do you want to have the 10 days oral?
Thank you, Martin. One more question.
If the asymptomatic family members, you swab them and you find they've got streps, do you treat those, or how far do you go? Because we have nurses who get very enthusiastic about spreading penicillin through the community.
Yeah. Well, the great thing about penicillin is that there is no resistance, and again, the Ministry of Health and Pharmac have had a campaign all through the 90s to don't give unnecessary antibiotics and don't give unnecessary antibiotics, but we, Pharmac, the previous Pharmac head rang me up and said, "You're accusing us of creating rheumatic fever." I said, "No, I'm not. I'm just saying that there needs to be a double message. if that person happens to be in a high chance of rheumatic fever, then you must look for group A strep. So I think that's been, difficult. You obviously, everyone's cost conscious, antibiotic resistance conscious, but the great thing is that penicillin is there's no resistance so far to the group A strep. So the answer to your question, finally, is yes, that's what they're doing, is treating other family members. However, there's no evidence that treating group A strep carriage on a population level changes your ARF rate. But that lack of evidence may not be the same as that's not true.
Which is interesting, considering the number of cases that don't have an identifiable sore throat or pharyngitis beforehand.
Sure.
Any other questions from the floor? Well, thanks again, Nigel. Here's a small token of our appreciation for joining us this afternoon. Okay, folks, so Nigel concludes the keynote sessions for us.